TopMedTalk.
Welcome to the first part of TopMedTalk's annual digest. This is a two-part programme which covers some of the most listened to pieces we've done in the last 12 months. If you're new to TopMedTalk and have been recommended to us by maybe a colleague or a friend, this is a great place to start. We provide free medical information for high-level practitioners and students each week. Make sure you register your approval on whichever podcasting platform you've found us on. A like and a subscribe from you now helps us reach more listeners in the future. Coming up, we're going to be talking about cardiovascular risk evaluation for non-cardiac surgery, perioperative patient safety and post-operative ward monitoring, controversies and standardization in prehabilitation, and the importance of intraoperative hypotension. First, though, we're going to look at should we delay surgery for prehabilitation, a piece which addresses controversies in prehabilitation for surgical patients. Andrew Davis, consultant in upper gastrointestinal surgery at Guy's and St Thomas's NHS Hospital Trust, explores the debate on whether surgeries should be delayed to facilitate prehabilitation. Firstly, who is prehabilitation for?
Prehabilitation is for all patients, not just the surgical cohort. And of course, this is something that was very clearly laid out by the Macmillan studies that were cited. A second caveat is that benign patients are just as important as cancer patients. They have less time pressure and should be offered prehabilitation, provided that there's an evidence base for that intervention. And of course, that needs to take into consideration the complexity of the surgery, patient characteristics, and resource limitations. But for the purposes of my talk, I'm going to focus on cancer surgery due to time limits.
The session delves into the various considerations such as proven benefits of prehabilitation, the optimal duration, risks of delaying treatment, patient views, and the complexity of balancing quality of life with survival rates. With a focus on cancer care, Andrew Davis explains the importance of prehabilitation.
If you give a patient chemotherapy and they don't respond, their survival is actually worse than a patient who didn't have chemotherapy at all. That is a stark reminder that if we put people into prehabilitation and fail in terms of compliance, we could also be doing them harm. After neoadjuvant chemotherapy, we often delay surgery for 6 or 8 weeks to allow recovery, but with the important caveat that they've had some anti-cancer treatment, and that will carry on delivering some ongoing effect.
The talk also touches on the need for improved prehabilitation programs and patient perspectives to be taken into account. It concludes with a call for more robust data and individualized decision-making based on a patient's specific risk-benefit profile, tumor type, surgery magnitude, and pathway. Andrew Davis makes it clear that good patient care must involve a patient perspective.
Because it's definitely not always what we think. They definitely have anxiety around treatment delay, and we see that in cancer clinics all the time. The moment it gets to 1 or 2 weeks of delay of cancer treatment without staging investigations, there are definitely questions that we are fielding from our patient group. And then we have to accept that there are a significant proportion who don't necessarily believe in or want to engage with prehabilitation. Taking into account patient views and perspectives continues to be extremely important.
You'll find a link to the full talk in the show notes to this podcast. This next piece we're looking at is called The Importance of Intraoperative Hypotension. Now, this is an ongoing topic here on TopMedTalk, and to some extent we feel that, along with our colleagues, we've really helped to highlight this issue. Here, Desiree Chappell and founding editor Monty Mython discuss the highlights of the annual American Association of Nurse Anesthesiology meeting in San Diego. After qualifying the problem with a discussion that shows intraoperative hypertension could impact the chances of surgical site infection, more so than, say, diabetes, we ask our guest how she's been looking at the efficacy of the Hypotension Prediction Index, or HPI.
When I first started talking about HPI with my colleagues and doing some lectures a year and a half ago, there was not a lot of studies out yet about patient outcomes with HPI. So now that you have this, it's amazing. And it's patients going into my lectures to show that, yes, like, I mean, yeah, well, because that was always the question. Okay, so you can avoid hypotension, but does that actually make a difference for the patients?
Yeah.
And yes, it does.
We cover familiar ground presented by this topic with what Desiree calls the Taylor Swift factor. It's me, I'm the problem. Have a listen.
As I've quoted Taylor Swift a couple times this week, it's me, I'm the problem. It actually is. I mean, it's the signal is there that the hypotension that we cause, I mean, because of what we have to do to anesthetize the patient, when we let their blood pressure go below a mean of 65, we can be causing some.
Is that fair though? I mean, I can see the association is clear. But Amy, I was brought up to believe that hypotension was relatively harmless.
That's what we always thought.
Meditation.
Right.
The conversation delves into the importance of data feedback and continuous education to improve patient outcomes. For more detail on this occasionally complicated topic, you'll find a link in the show notes. Now, this piece, behavioural change versus psychological interventions, which is key in prehabilitation, is well worth hearing in full. It's a talk which was given by Liam Humphreys, Senior Research Fellow and lead of the Living Well with Chronic Disease Research team at the Advanced Wellbeing Research Centre. It was given at the Prehabilitation World Congress as part of a series of presentations under the heading Controversies and Standardisation in Prehabilitation.
Each patient is unique. And that person has their own characteristics, their own needs, and their own preferences that need to be considered within their prehabilitation plan.
Liam Humphreys discusses the significance of psychological and behavioural interventions in prehabilitation.
So I'll come back to the original question. So what is key for prehabilitation? Now, unfortunately, I'm not going to give you a definitive answer. So what I'm going to say is that, in my opinion, that we need to recognise that they are both mutually beneficial and important within prehabilitation.
He delves into the definitions, differences and evidence supporting these interventions and the importance of person-centred approaches.
We need to make sure that these interventions are developed with person-centred approaches, and this will also increase engagement. Now, engagement is key, and again, I say it's come up in most of the presentations again, because we do run the risk of increasing the health inequalities in these sorts of research, where we're only accessing the people that probably would have done the health behaviours themselves anyway, and the people that could probably stand to gain the most are probably being left behind.
Humphreys highlights the psychological challenges faced by patients with cancer diagnoses and the impact of psychological support on surgical outcomes. He reviews studies on prehabilitation showing positive outcomes, but notes the lack of detailed intervention descriptions. He also discusses the positive impact of psychological support and resilience building on patients undergoing treatment.
These findings show that having some psychological support and building people's resilience could have a really positive output on people as they go through their treatment. So in terms of some of the data on this, so there's a scoping review by Hanalis Miller in 2022, who looked at 44 prehabilitation studies. The graph on the left side there looks at which is the most popular form of psychological support, and psychoeducation was quite far ahead. And some of these examples have been discussed today, which would look at, like surgery school is a good example of this, where you are preparing people for what's ahead in terms of their treatment.
Emphasising behaviour change as vital for prehabilitation, he advocates for mapping behaviour change techniques and using frameworks like the COM-B model.
The best interventions are underpinned by clear theories that explain the what, explain the why, and also explain the who. I wanted to sort of answer, when you're designing an intervention, is being able to ask these questions. Is why is the intervention needed? What is the intervention? What does it need to do? And why is the intervention important? And what will it achieve? So these are sort of things to help us design. And the COM-B model and the behaviour change wheel can be applied to these as well to make it quite a robust process.
Now, we can only really scratch the surface with a few clips here, but we highly recommend you go and have a listen. It's one of 2024's standout pieces, and it's part of a series here on TopMedTalk. You'll find a link to it in the show notes. Another piece we'd like to draw your attention to, again linked to in the show notes, is perioperative patient safety and post-operative ward monitoring. Sadia Khan, consultant cardiologist at West Middlesex University Hospital.
It's not about the technology, it's about the people, both in terms of process, but also in terms of those outcomes, because unless we can really say we made a meaningful difference, I'm not sure why we should bother. We just shouldn't, should we? So for me, that issue of which patient, I think with my physicianly hat, I looked at it very differently when I first started this work. And I've been doing work in this monitoring space in an inpatient setting probably for almost close to a decade now. So quite a long time.
Sadia is in conversation with our host, Desiree Chappell, and Marco Lucetti, anaesthesiologist and medical director for patient care solutions at GE Healthcare. Here they address sudden deterioration in the ward.
Actually, they are not suddenly deteriorating. They are suddenly found to be deteriorated. That's the crucial point.
My favorite quote recently has been, "It's gradual until it's sudden," which was a quote about bankruptcy, but I think that it is very, very appropriate for our patients.
Yeah.
It's a fascinating piece. There's a link in the show notes. We highly recommend it. Finally, in this, the first of a two-part podcast, we're looking at cardiovascular risk evaluation for non-cardiac surgery guidelines. Presented by Andy Cumpsty and Geoff Lacey, with Mark Edwards, consultant in anaesthesia and perioperative medicine at University Hospital Southampton, honorary senior clinical lecturer at the University of Southampton, and John Whittle, clinical academic working in perioperative translational medicine at UCL and honorary consultant in perioperative medicine, anaesthesia and critical care at University College Hospitals, London. John Whittle here speaks about the importance of understanding functional capacity, the key to better surgical outcomes.
You've got to start with a few ground truths and to say, well, we definitely know that reduced functional capacity is associated with adverse outcomes after surgery, including adverse cardiac outcomes. We know there are a bunch of ways of assessing functional capacity, from questionnaire, DASI is the common one that we talk about, Duke Activity Status Index, to asking the patient. Not necessarily a reliable tool, and that was actually quite clearly brought out in a variety of studies. Asking the physician what they think the patient's good at, METS quite clearly showed that, amongst others, that we're not great at judging our functional capacity. Measuring it by asking the patient to climb some stairs with you or not. 6-minute walk tests, 6-minute step tests, sit to stands, CPET, which of course are highly available in both the Mark and my centres, and I am an enthusiast for it.
John Whittle again.
MINS stands for myocardial injury after non-cardiac surgery. It's currently defined as a greater than 99th centile increase in troponin, as in for your lab reference value. The type of troponin, I think broadly, is not specified, that it may become important for obvious reasons. And I think the current definitions continue to include MI, whether it's an ST or non-ST elevation, because that is a type of myocardial injury. However, that clearly has a slightly separate and definitely cardiac management implications. I guess MINS as well, in terms of troponin rise, the degree of troponin rise has prognostic implications. So, if your reference lab upper limit is 14, a troponin of 15 on day 1 to 3, it's normally within 48 hours of surgery, abdominal surgery being the most common in the literature, has a lower risk of complications as compared with a higher, like a 90th centile rise. So there's, even within MINS, there's different degrees of myocardial injury.
Mark Edwards now on the subject of cardiopulmonary exercise testing, CPET guidelines.
The guidelines do not really go heavily at all on CPET. And that's obviously interesting for our context. It makes you realise, actually, I think a lot of European practice is to not have CPET within their preoperative workup. Ditto the US practice, from John's experience. It does change your approach to these things, because you've got a gold standard test of functional capacity, which also happens to give you information on cardiovascular performance. So that does kind of skew the degree to which you feel you want to get that echo.
For more detail on those guidelines and that conversation, go now to the TopMedTalk show notes for this episode and download the whole thing for free. Thanks for joining us here on TopMedTalk. Don't forget to subscribe. We have a plethora of offerings for you on YouTube. We've also, of course, got the podcast that you're listening to now. And there is the website edpom.org, because TopMedTalk is the broadcasting arm of EdPom. So if you want to check out evidence-based perioperative medicine, who organise conferences around the world celebrating, advocating and investigating evidence-based perioperative medicine, that's the place to go. edpom.org.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EdPom, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is edpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. edpom.org.